Susie Keller, you're back. How are you?
Happy 2026. I'm doing great.
Happy 2026. I feel like the first 3 days of this legislative session are going much better than last year. This is what I feel.
Good.
I remember last year, people were like, oh my God. People were in tears. They were freaking out. Like our pets' heads are falling off. And this year, people were like, yeah, we're just, we're going to see. It's like people jockeying for position, trying to feel it out.
Roll up our sleeves and let's get to it.
Just get after it. Listen, you are the executive director of Idaho Medical Association, IMA. You're the largest physician representative body in the state of Idaho.
Correct.
You represent their interests and their little nuancy things. What are we talking about today?
We are talking about some of our priority issues that we are hoping to talk to the legislature about, hopefully advance some legislation in a couple of areas.
Love legislation. Okay, so what are we doing? What's the legislation?
So we have 4 priority areas, the biggest of which is physician workforce. Newsflash for everyone, we have a physician shortage in the state of Idaho. Very happy that our legislators seem to embrace that over the past couple of years and understand that. And there's been a lot of different conversations and ideas about what to do about it. There was a committee during the interim studying undergraduate medical education. That's the first part of medical school of becoming a doctor. I have been on your show talking about the secondary part of that, which is graduate medical education, residency training. But there's a whole lot that we can do. And so the IMA is very much invested in how do we continue to ask the state to invest in GME, residency training in the state of Idaho, because we are very good at keeping those docs here after they complete their training.
And GME is general medical education?
Graduate
medical education. Okay.
So it's the phase after medical school that determines what kind of physician you are going to be. Are you going to go into family medicine, psychiatry, OBGYN?
Sure.
That happens in residency, and you can't be a practicing physician without having done that.
Okay. I had Dr. Rami Geidel on twice, and
great.
she said undergrad medical school, and I was like, oh no, does she mean like undergrad? Okay, so the point is, this is how it works. I go to high school, I graduate high school. I go to a 4-year, get my undergrad, BA, BS, whatever it is. Then I go to the undergrad med school, as she termed it, which is, doing small clinical things and
4 years.
Right. And so we go around and I do, I learn a bunch of book stuff, and then I go do clinical rotations all throughout the area. So I do like 6 weeks here, 6 weeks there, and I'm tasting everything. And then that's and then the graduate is like, now I go in as a resident, because I'm like, I really like ENT. I want to be an ear, nose, throat doctor. I'm going to go work as an ENT with these ENTs exclusively for either 3 to 5 years, depending on the specialty. And then at the end of that time, I am an ENT doc.
Yep.
Right. And obviously there are tests and checks along the way. The thing that is hilarious is her second episode is publishing tomorrow. And in the description, we're talking about University of Utah and the medical school and collaborating with them to some degree to improve physician workforce. And I was like, and this could be great in about 15 years. Because if you're growing someone, we have a graduating senior from high school right now, 4 years undergrad, 4 years of medical school, 3 to 5 years of residency. You're looking well into double digits. It's like, you're never like this. We're talking 20, 40 something before that person hits the street as a practicing physician.
Yep.
That's wild times.
It is. And that's why we are so grateful of everything the legislature has done thus far in supporting medical education and the residency training piece. We need to do more on the residency training piece, and the state's been great. We had a 10-year plan that we have been advocating for from the Idaho State Board of Education, and we're 8 years in. And so we are looking to ask the legislature to continue to allocate state funds to help grow that program. So that is one of our legislative initiatives. And another thing that we are going to be pushing for this year is putting more state resources into physician loan repayment. When a graduated doc comes out of training, a lot of times they have upwards of $250,000 to $300,000 worth of educational debt. So the state of Idaho has an existing program that has a 92% retention rate of helping with loan repayment for primary care physicians in rural areas of the state.
So that means if you have 100 docs that accept this loan repayment program, 100 docs go out into rural areas, they start practicing, and they're there for X number of years, like 4 years or something.
Correct.
What's that?
100 is really...
It would be wild.
It
That'd
would
be
be
wild.
awesome right now, where if we can do 18, 19, we're doing well.
Sure. But you said 92%. So I'm like, 100's an easy round number for 92%.
There you go.
Okay. So the bottom line is you have people that go out. If you had 100, they went out. 92% of them would stay in that community or Idaho once the funds are repaid, once they get their tuition reimbursement, essentially.
Yep.
Okay, so that's an incredibly effective way of attracting and retaining doctors.
Absolutely.
Got it.
And here's another cool thing. So the IMA partnered with the Idaho Coalition for Safe Healthcare, and we just had a study published in December on the economic impact of physicians in the state of Idaho. So we're talking about, we know physicians take care of patients, and it's great to have them in all of these rural areas. But Matt, did you know?
Did you know?
Did you know that Idaho physicians, whether they're practicing part-time or full-time, on average contribute $1.3 million to Idaho's economy?
Okay, look, that's like monopoly money, so you're going to have to help me understand this, because it's not, that concept is not that they take home a $1.3 million salary.
Correct.
And it's not. Okay, so like, what does that mean? If you're saying you contribute this amount of money, is that like, okay, let's say you make $400,000, banger amount of money, but you're a doctor and you spent, 20 years becoming a doctor. You make $400,000. Then you spend a large share of that within Idaho. So you have to build a house, you're going to go out to dinner, you're going to do all these things. That money then spins off every dollar you spend supporting the rest. Is that like the multiplier effect? Is that what you're talking about?
It is generally supporting the economy. So not only the individual's contributions to the economy, but each physician also in our state supports 12.26 jobs.
So it's the infrastructure around that person.
Correct. So it's the physician plus the wonderful nurses and support staff and administrative
janitors,
staff, billing,
sterile
coding, all of
techs,
those
everything.
things in the healthcare sector. So each physician supports that many jobs in their own little ecosystem. So it's supporting those jobs. It's the state and local tax revenue as a result of the individual and the employees participating in the economy, paying their taxes, etc. So that all adds up to that $1.3 million impact of having a practicing physician in your community. Not only contributes to your community's health and wellness, but also to its economic health as well.
Well, I can tell you, just from my perspective, I don't do that with a podcast. I have zero supporting staff. Like, I am not good for the community. If they're like, we need more podcasts just sharing rural life. You don't need any more.
Right.
Yeah. Okay. So that's just each physician then.
Correct.
Right. So on average, it's over like $1.25 million of impact. And that's individual spending, consumption, but that's also other jobs that spin off, or you're paying rent. You have to have, the roof, everything.
All of the things. And we do have the full study that's available. I'm just sharing some of those high top line numbers. But I think it's important to think about those things. And I should say that we did work with an economist from the University of Idaho who has a lot of experience in doing these sorts of studies.
Who is that economist?
His name is Stephen Peterson.
I would love to talk to Stephen Peterson.
He's a super smart guy.
The thing that I'm very fascinated about with University of Idaho, they followed me, by the way. U of I followed me on Instagram. I was like, I have arrived. God bless it.
Nice.
I've been interviewing a lot of their deans, and I also spoke with a gentleman by the name of Sam Eaton. He's the Potato Commission Government Affairs, right? So he's their lobbyist. What I find very interesting is largely the conversation around universities for the time I've been alive has not been around what the original utilization of university systems were, at least one of the fundamental pieces, which is research, right? Like the Potato Commission had this problem with this, it's like powder something disease, right? And they're like, oh no, this is really bad. So you have these potato growers who are like, hey man, we have this problem. Remember what happened in Ireland? It's bad. Like we need to take diseases seriously. But they don't have labs and they don't have scientists like working in those labs. So they were like, hey, U of I, could we like work with you and you figure this out? Now, U of I has the scientists and has the labs and they're like, yes, man, like we've been waiting for this problem. Yes, let's do it. And the similar thing with economics, like we need to know what this is. Is there anybody in the office that can crunch these numbers? And everybody's like, I mean, no, right? And then it's, okay, well, who are those people? Where are they? They're in the university system, right? This is the hotbed for like the brain trust,
right.
As it used to be considered, where you could go with problems, and they had the people that had the time and the interest in being like, this is really complex, but give me a month and I can get you an answer, and I will back that answer up with data. I'll show you my methodology, all of these different things, and by the way, I know how to do this. And you're like, yes, please, Stephen,
right.
Go,
let's go.
Yeah.
So that's the end result, and we're really pleased to have this information because it helps us quantify, hey, state of Idaho, when you contribute or help allocate $100,000 of loan repayment to a physician in a rural area, that's like a 13-to-1 return on investment when that physician is generating over $1 million of economic activity in that community.
I think you did the math wrong. That's 1.3 per year, right? That's not gross, like over the life of the physician. Like if you say there's $1.3 million of economic activity derived by these 12 jobs, derived by the physician's job, derived by all of these different things, that would be within a calendar year. Your repayment program is $100,000 over 4 years.
Yeah, so
it's not 1 to 13, it's 1 to 52.
Okay.
So because the 1.3 million times 4 is $5.2 million. So if you make the assumption, like we draw this physician in under the hope that he or she is going to come here, spend 4 years here, that physician's like, hey, this is a good enough deal. I like Soda Springs, whatever. And like, I'm going to get this I'm going to get $100,000 to be here. Awesome. That person comes in. And if we make the assumption that they do act in the manner that you're describing, which is, okay, now we have the 12 supporting jobs. Now this person's buying a house. They're spending money. All these other people that now have jobs are, buying houses and spending money. That multiplies times 4 over the course of that repayment.
You are correct.
That has got to be the wildest ROI of any program. 1 to 52 is crazy.
That's pretty good.
That's pretty great.
Yeah.
Snap, Susie Keller. Look at you. Awesome. And when you were talking about the GME, the graduate medical education, and you were saying, look, let's fund more of this. Now, there are several areas where we don't have residencies, and the residencies are where the person goes through undergrad, goes through the second undergrad, then specializes, is like, I want to do anesthesiology, or I want to do OBGYN, I want to do whatever. That's when they go into that residency program. Now, Idaho doesn't have an OBGYN residency program, and that is being held up. I think it was Dr. Jim Souza who explained this to me. I know it's been explained to me 1,000 times, and I'm like, I don't understand still. But again, the idea is it takes a lot of funding to do that. And you get the funding from many different sources. One could be the government, one could be an actual hospital system, and then there's like a third one that he mentioned. It's like the state. So it's like the federal government, the state, and then the hospital system, all to come together and say, we need a teacher, and we need a location, and we need a way to get students here. And unless you have that the established teacher that's going to teach the residency and the location, and then you get residents that are willing to come in, none of that works. But it starts with, we can't even start this conversation until we have like funding for a teacher and a curriculum.
Absolutely.
Okay.
And you also need to locate it in a place where there's enough patients and enough pathology so that they get the full scope of training that they need.
So you can't have them in rural places. You're like, we need a very, very high probability that this person will be seeing, let's say OBGYN, will be dealing with deliveries, complications, all kinds of things all day long. Because if the frequency is too low, or if they don't see the variety of disease treatment, then they will be ill-equipped to effectively go out and, engage the world in 3 or 4 years, whatever it is.
Exactly.
Okay. So that's why we need them in like Boise or Nampa or whatever population center.
It'd probably end up being Treasure Valley.
Somewhere.
Yes, I'm guessing, in order to have the number of patients and pathology. And it's obviously, given our trouble with having OBGYNs outside of those major metropolitan areas, that would
That'd be a
speak to
thing.
that as well.
How much money would it take to get an OBGYN residency?
I have no idea. What I can tell you is that when Idaho submitted its application and was recently rewarded from the federal government Rural Health Transformation Program, that was part of what Idaho asked to be able to look at and allocate some money to standing up that type of residency program. But I don't know what the dollars are.
Gosh, man, this is a crazy one. Yeah.
Yeah.
Okay, so you guys aren't really asking then directly to bolster you're not asking to start new residencies. You're asking the legislature to continue supporting existing residency program like pediatrics and other things.
Yes. So right now in Idaho, we have family medicine, psychiatry, pediatrics, and internal medicine. And obviously we have some budget crunch issues. And so in terms of putting forward a budget request, for growing GME, it was absolutely scaled back to the minimum and just trying to build out the programs that were started. Most of the programs in Idaho are 3-year programs. So in order to become a family physician, you do 1, 2, 3 years of residency. When we start a new residency, we have funding for that year. But then in the second year, you have people who are first year, people who are second year, if we're going to continue to
Sure.
grow it. So we're just asking the state to fulfill their obligation to allow the build out of those seats that we started a couple years ago.
Gotcha.
So very much scaled back.
Is there any discussion about funding, or perhaps it already exists, but funding fellowship programs where you could have like a family practice physician who also wants to do a fellowship in like OBGYN or something like that? So you don't need the residency program per se, but you do need a program that can help them derive or become skilled with that specific specialty so that they can be a stopgap for a lot of the problems that the state is facing because of scarcity of OBGYNs.
Yes. And in fact, last year, JFAC passed some intent language. So they mostly do budgets, but every once in a while they say, hey, by the way, here's a policy statement or intent language that we have to go along with this. So they said, hey, GME committee, under the State Board of Education, we are allocating funds to continue to grow residencies, but we want you to look into establishing a new OB fellowship for family medicine residents in the state of Idaho. So look into this and send us a report back. The report was due October 1st. So the committee submitted the report, and part of this year's budget request does include a new OB fellowship for family medicine in Pocatello.
Hell yeah, Susie Keller.
So
That's
these guys
awesome.
are stepping up.
That has been described to me as perhaps really one of the only tools in the near term that Idaho has to get more OBGYN capable individuals, right?
Sure. And I would be remiss if I didn't take this opportunity to say family medicine physicians are trained quite robustly in taking care of OBGYN issues.
OBGYN adjacent.
Yes, exactly. Taking care of pregnant moms, delivering babies, etc. However, there are many issues that come up throughout a pregnancy that may require surgical intervention, a cesarean section, for instance, those sorts of things. And so those surgical interventions do require an additional level of training that is above and beyond the robust maternal medicine training that family medicine residents get. And so that, to your point, does expand what we are able to provide.
Gotcha. Do you represent midwives as the IMA?
We do not. Our membership is for physicians, so an
Gotcha.
MD or a DO, practicing physician, licensed in the
But
state of
not
Idaho.
midwifery.
Correct. And many of those are nurses, not all, but many are nurse specialists, but not all of them are.
Who represents the nurses?
There are a variety of groups, actually.
Oh, like who? You've been holding out on me. I thought you represented all medical people.
No, we're a physician
Just
organization.
physician only.
Just
Okay.
physician organization.
Yeah. I just asked because a friend of mine, his wife is going through training to be a midwife. And
Awesome.
Again, in all of these conversations around anxiety with women's healthcare, it's like, okay, look, there's got to be something like, okay, we have these big Goliath-esque problems, no residency program, and what people would articulate as less favorable legislation. Some people don't believe, some people do, whatever. It's like, okay, all of that's fine. What about the women? Like, what about the moms to
Where
be?
do they
Like,
get
what,
care?
like brass tacks? Like, we need to do something. And the two of the big things were that have spawned out, which I'm so happy to hear about. One was the Fellowship for Family Practice. Like, okay, that's great, because somebody had just, it's like I read all this nonsense online and I'm like, oh, okay, so it's not fake. Okay, great, that's good. And then midwives are the other piece. And I think it was Dr. McEachern who had brought up the concept of having labor and delivery wards where you essentially have force multipliers of the OBGYN. So you have an OBGYN that's like overseeing a ward, but then you have individuals doing the actual delivery. And, most of them occur, hopefully without incident. So you don't need the full attention of an OBGYN through the entire thing. You just have people that can do it. And then when you do have a problem, the OBGYN can pop in.
Mm-hmm. Absolutely.
Yeah, it's good times. Okay, so predominantly, look, we're going to ask you for some money. How much money is dedicated to the rural repayment program, like every year?
So the Rural Physician Incentive Program, that's loan repayment,
Sure.
otherwise known as RPIP. That is predominantly funded by fees that Idaho students that attend WWAMI or the University of Utah medical education programs, they pay in fees into that fund. So that was the main source of its funding for a long time. And then several years ago, Representative Vanderwoude, as a matter of fact, was the sponsor of legislation to provide a 2-to-1 match of state funding into that pool.
Oh,
and so
yeah.
it's mostly state dollars and then also supplemented by these student fees. So it has really increased the number of awards we're able to give
Sure.
every year. So that's a big deal. In his budget, the last 2 years, the governor has recommended an additional $500,000 allocation. That's basically 5 more physician awards. And unfortunately, it didn't pass last year. It did pass the year before. So we kind of had a bump in
Gotcha.
number of awards. But so that's how it's funded.
So each year, how many new awards, or how many awards are you giving out?
It varies from year to year. This last year, we were able to fund, I'm trying to remember, I want to say 18. And the year before, we were able to do closer to 23.
Okay, so each year it's 20 times the number. Like each year it's 20, or roughly 20 times the $5.2 million. So if it's costing us, let's say 20 payouts of $100,000. Okay, $2 million. Great. But that $2 million accounts for 20 times $5.2 million, which, if my math is not wrong, is $104 million of economic activity.
I'm going to have to trust you on that one, Matt. I've not done this.
All I'm saying is if you did 20 last year and we agreed that over the course of 4 years, you get $5.2 million of activity for each physician, that's just 20 times that number. That's an unbelievable number. That's amazing.
It really is amazing. And each year, those are the new participants in the system, because they get $25,000 per year for a 4-year period, as long as they are practicing and accepting
Yeah.
Medicaid, Medicare patients, etc.
Oh yeah, man. That's pretty wild. I need to talk to the economist, because I would love to know how he came up with all of these little things. Because again, to me, it's like you could say 12, you could say 5, you could say 20. I don't know. I don't know, because I'm not hanging out with a bunch of doctors all day long. Like, oh yeah, I see all the people supporting these individuals. But understand, it's like, okay, look, this is what we actually have. Like, we have a hospital of 100 doctors, and within that hospital, we actually have 1,200 employees, right? So if those doctors didn't exist in that hospital, none of those 1,200 employees would exist. So we don't even need to categorize each of them. We know that you need like 0.07 of a janitor for every doctor, and you need like this many sterile techs, and you need this many mechanics, and elevator repair guys. You need all of these people. So what you do is you look at the gross number of employed individuals through an entity that could not exist without these physicians, and then you just derive the average from there. I made all of that up. So I'm just wondering if that's kind of analogous to how he does it. Because if that's it, then you're like, oh, that makes perfect sense. So if you had a place that had like 10 doctors, you'd likely have 120 people gainfully employed in some manner in that area. And it's like, yeah. And in fact, I bet it would probably get, because you get economies of scale. So you'd probably get even more employment on average as the number of physicians in a certain centralized area decreased. Mm-hmm. And again, I made all that up. I don't know.
Well, he would be able to do a deeper dive into the technicalities of how he made his calculations in the report. That is not my forte.
Not your thing. I like that you kind of like just black out as I like go into like a number thing.
I am not good at doing math in my head.
Oh my God. I love math. I love math so much. It's so fun. Like, I love playing with numbers. They're just great. But bottom line is, big, and again, I know you have lots of priorities. We're not going to cover them all today, but one of the biggest is explaining from a financial standpoint. It's like, look, there are ROIs we get with our funds, right? Every dollar going out, we want, especially with taxpayer dollars, needs to be working as hard as humanly possible. And there are some that give you like a 2-to-1 return. There are some that give you a 50-to-1 return. But like, that's the idea, that ultimately IMA and investing in physicians gives you an astronomical return that should be absolutely considered.
Yes, we feel like this is a good use of state dollars, is educating physicians who will stay and practice here, helping retain those physicians and keep them practicing in rural areas. And
you make a lot of money. And it's good for the economy.
And it supports our economy in all of these different ways.
This wild times. I know we're kind of running short on time. It's a working day. But were you really ecstatic about the grant that we were able to secure? Or I've heard both ways. Some people are like, yeah, look, it's really, really good. And other people are like, yeah, they gave us 2 because they took away 10, right? So, I mean, nobody's going to be mad that you got 2, but a lot of people are frustrated that we lost 10.
Yeah. And so the Rural Health Transformation Grant was created as a attempted backfill at these huge cuts that are coming to Medicaid programs across the country. So in the coming years, Idaho is going to have some pretty severe cuts that are going to impact our rural hospitals. And this federal program was an attempt to say, hey, let's backfill some of that. And it was created in such a way that it was very specific. So you couldn't necessarily say, well, this program was cut, so this money can backfill it, because it's only for a period of 5 years. So they very much were emphasizing not backfilling things that will need to be sustained into the future, but here's one-time money for this or one-time money for that. And so it was difficult, and I do give credit to the state for threading that needle of trying to say, well, our needs are here, but what we can do with our application is here, and trying to make those things fit.
Yeah. Yeah, it's intense. I have Brian Whitlock from IHA coming on Monday, so that'll be. And
here's the thing about Brian. His eyes will not glaze over when you talk about numbers, because he'll be right with you.
He'll be right. God bless it. Susie, thank you for coming in. We just hit one of the priorities. Please come back. Let's keep talking about what you guys are working on. I appreciate you. Is there anything you want to say here at the end?
No, just thank you for the opportunity to visit.
Always. Thank you. We'll do it again.